Hi, everybody.
Hello. Hi, everybody, and a very warm welcome to this ENETS INCA Cancer Net Day seminar. I think we are looking forward to a fantastic 2 hours with good discussions, and I hope you will enjoy this. My name is TIENSUU JANSON, and I'm the chair of ENETS.
Hi, and I am Mark McDONNELL. I'm the president of INCA, the International Neuroendocrine Cancer Alliance. I'm also a patient myself, and I'm looking forward to today's discussion, and thank you all for joining us.
Yes, and I would like to start the next slide with introducing the speakers of today. And we have the pleasure to have a very nice set of speakers here. So we have Anna KOUMARIANOU, who is an oncologist working in Athens in Greece. Very welcome. We also have Emanuel CHRIST from Basel in Switzerland, and Gregory KALTSAS, who is also from Greece working in Athens. And for the final session, we will have Stefano Partelli, who is working in Rome, Italy, and Hans Hofland, who is working in the Netherlands. So I think that with this fantastic panel, we will have some good introductions to the subjects that we are going to hear about today.
Next slide, please. So we also have a slight change in our format from last year, whereas last year we had presentations and question answers at the end. This year we're going to do it as more of a roundtable discussion with a panel of experts and patients and nurses. So our discussants that are joining us today, along with our speakers, is Professor Andrea FRILLING, who's Professor of Surgery and Chair in Neuroendocrine Surgery at the Imperial College in London. Anja Rinke, who's the head of gastrointestinal tumours and the ENETS Centre of Neuroendocrine Tumours in Marburg, Germany. Wanda Helvet, a nurse specialist in endocrinology from Erasmus in the Netherlands. Wendy Martin, a NET nurse specialist in King's Hospital in London. And we also have 3 patient advocates who themselves are patients. Dr. David Bartlett, a GP in the UK, diagnosed in 2017. Kate Quirk, also from the UK, and she was diagnosed in 2003 with lung NETs. And we have Duncan McDONNELL joining us from South Africa, who was diagnosed in 2021. So we're going to have a lovely roundtable discussions on the topics that are raised during our sessions.
Thank you. And the next slide, please. So this is the outline of today. And the first session will be about the diagnosis and treatment. And here, Anna KOUMARIANOU will have a short introduction, and then we will have a discussion about the new and old ways of diagnosis and treatment for our patients. And the second part will be focused on patient stories. So we will have a couple of videos with patients telling their story, and then we will also hear the clinician's perspective from Emanuel CHRIST. The third part will be about genetics in thoracic and digestive nets. This is interesting because it's an area that is developing rapidly, and we are really excited to have Gregory KALTSAS to talk about this, and then have a good discussion afterwards. And then, of course, we want to know what is coming down the track. So the final session of the 4 will be committed to that subject, and we there have 2 people that will set the scene. It's Stefano Partelli and Hans Hofland. So I think this will be quite exciting, and I hope that all of you who are here listening will also have a lot of questions that you can put in the poll, so that put in the chat, so that we can ask the questions to our panel during the session. And then I have another question for you. So the next slide, please. We would really like to know where all of you who are watching us, where you come from. So it would be very nice if you would just mark which continent that you are from. Please do so, and we will go ahead and see what is happening. I hope that there are many people out there who are joining us today. And I cannot really see the poll, what is happening. So let's see here what is going on. Still a lot of people that are marking where they come from. Looks very interesting. So please mark where you come from and let us see where you are from. Most of you from Europe, and then a few from Asia, South America, and Australia. So thank you. Yeah, still a few more coming in, so please continue telling where you're from. I think this is interesting for us to know how far we can reach out with our program.
Can I jump in there,
Yeah,
Eva, and
please.
just say that underneath the streaming that you're seeing of the webinar, there's a box which allows you to ask questions. So, you know, we really encourage you, if you have a question, type it into the box and hit send. And during our sessions, we will be trying to put those questions to our panel of speakers and discussants. So please participate by asking your questions.
Yes, Mark and I will try to keep track of your questions and put them forward. But I think it seems that we are all set. So as you can see, we have our main number of people from Europe, but also from other continents. So this is what it looks like then. If you want to put your question, please type it in here, and we will ask the question to the team that is discussing the topic. And afterwards, we would really like you to also fill out the participant survey, because it's good for us to know, was this a good format? Was this understandable? As we heard from Mark, did we use a lot of difficult words, or could you follow the talks and also the answers to the questions? So please let us know what you think. We really look forward to getting that as well, your opinion about this webinar. So now I think that we are ready for our first session, and it's a great pleasure for me to introduce Anna KOUMARIANOU to introduce diagnosis and treatment. So please, Anna.
Thank you very much. I'm very excited to be among you. It's a wonderful day. It's a big celebration, and I'm delighted to go through with you the basics on the diagnostic and treatments of neuroendocrine tumors. Next slide, please. So I'm sure you're aware that neuroendocrine tumor is a form of disease that can develop in any part of the body, and it can most commonly can grow slowly, but sometimes quickly, and spreads to other parts of the body. Well, sometimes it's very interesting that neuroendocrine tumors produce proteins that cause hormonal symptoms, for example, diarrhea, flushing, or hypoglycemia. So we need to deal with both symptoms and, of course, the tumor growing in the body. Next slide, please. So when we come to see how the diagnosis is made in patients with neuroendocrine tumors, what are the first steps? Then we need to think on two pathways. The first is to get a biopsy, a histological diagnosis. And this is carried out, of course, through the bioptic procedure. And then we take the sample and we do some special procedures. And then we see the tumor specimen under the microscope. And we, of course, do some more tests on that. And we establish as much as possible in detail the diagnosis and the characteristics of the tumor. For example, maybe you have heard of the Ki-67, which is the rhythm that cancer is growing. Of course, there are some more modern procedures that we do on the tissue. For example, modern immunohistochemical tests, or even molecular tests that we may need to discuss later on in this meeting. The second pathway we follow in these patients is to establish the extent of the disease. And this, we have some tools we can use to establish the staging, if you can, maybe you have heard calling it. So the staging is being carried out by some imaging techniques that NET experts are mostly fond of, which are the computerized tomography or CT scan, a magnetic resonance imaging or MRI scan, and a more new technique, which is called PET scan, which is a scintigraphic method. We use isotopes to do this test, and this test is being carried out most commonly either with gallium or with FTG, which are tracers that can image tumor cells that are growing either slowly or rapidly. So we combine these two image tracers into different tests to get more information. Next step, please. So we have done this test, we have established the tumor characteristics, and then we have to decide what's best for our patient. So we do a multidisciplinary meeting. We put all these parameters on the table, and all the different specialists discuss about the possible options of the patient we are discussing. And of course, we have the surgical treatment that is being carried out once the disease is at a very early stage, or if the disease has advanced, then we may discuss other treatment options, such as these shown on this slide. For example, we have the somatostatin analogs that target the somatostatin receptors, which are specific protein receptors on cancer cells. And this injection is being carried out most commonly once every month, and is a very nice, as patients are telling us, treatment, because it's hassle-free, they don't have to make lots of blood tests, etc. And is a first level treatment. Then we have some more treatments available. For example, we have targeted therapies. Most commonly, these are tablets, which of course is a very nice option for our patients, because our drugs taken at home, and most commonly they are used every day, and they target specific pathways of the tumors, such for example the mTOR and angiogenesis. The third option is chemotherapy, and I'm sure you're all aware that this is most commonly an intravenous treatment, but in neuroendocrine tumors we have also chemotherapy tablets we can use. Fourth treatment option is the radionuclide therapies, which are more modern approaches that use therapeutic isotopes. And the most commonly used is lutetium isotope. And of course, at the end, and most importantly, we have the drugs that control symptoms. As we said in the beginning of this presentation, sometimes patients may have symptomatic evidence of a hormone disease, for example, hypoglycemia or diarrhea, and then we have to use drugs that specifically target these symptoms. And at this point, I finished my presentation, and I bring the microphone back to our leaders, Professor TIENSUU and of course Mark Tower. Thank you very much.
Thank you so much, Anna, for this very nice introduction. And we are also now welcoming our discussants, Andrea FRILLING, Wendy, David Bartlett, and Duncan. Oh, I cannot see your name here because it's so.
Duncan McDuff.
McDuff, sorry. So let's then start the discussion. And I actually have a question here because I got a question in the chat. So the question is there any approved treatment for NET at the moment? What would you say? What are the approved treatments?
Do you want me to reply?
Yes, please, Anna.
Thank you very much. You know, as a neuroendocrine tumors is a relatively rare form of cancer, we don't have a very high number of clinical studies indicating the benefit of this drug. So there is variability among different countries which is approved and which is not approved. For example, somatostatin analogs like lanreotide and octreotide are approved drugs, as far as I know, in all the countries. The use of these drugs is very well supported from large clinical studies. It's FDA and TMA approved, so it's from the Food and Drug Administration of the USA and the European Drug Association. So these drugs are approved everywhere. Now, if you go to see the other types of drugs, for example, the tyrosine kinase drugs, these are mostly approved within the European countries, but there are still some countries around the world that these drugs are not available within this field. If we go then to see, for example, chemotherapy is not very well supported, and in many countries within the European area or even in other parts of the world, we have to follow different pathways to get approval for each patient specifically. And at the end, I also discussed about the radioisotope treatment, which again is not widely approved, nor within European countries, nor within the rest of the world. And again, like in my country, in Greece, we need for each patient to obtain a specific approval to use by the Ministry of Health. So we have very, very few treatment options widely approved. And then I think that most of the rest of the drugs are going through individual per patient approval within most of the countries. I hope I have replied to your question.
I would add to that you know, there are the range of treatments that are, you know, available, but a patient really, for the best care, every patient is unique and everybody's patient journey is unique, and I would say that for the best care, a patient really needs to be treated by an MDT. You need your consultants with a range of different perspectives to discuss your case and come up with the right treatment plan for you. And I would urge all patients that, you know, in working with your clinicians in the hospital, you know, you really push that, you know, if you're not with an MDT, you know, try to find a hospital that has an MDT, and particularly, if possible, a NET specialist as well, because the disease is quite complex.
Yeah, maybe to add, I think it's a great question. Maybe to add to that, I think, you know, from a patient's perspective, you know, certainly in the early days when you've just had your diagnosis, in addition to kind of pushing to try and get treatment from an MDT where you are getting the input from a panel of experts, it's also really making sure that you're asking all the right questions to understand what treatments are available, because it may be dependent on the specifics of the country you're in, or you know, what treatments are available through state healthcare or on private medical aid, because, you know, given the uniqueness of the disease to each individual and the different location of the primary and whether it's metastasized, all of these things are going to influence what treatments are available to you and in what order you might work through the sequence of treatments that are available.
I would like to add something to that, because I always experience a lot that patients need to have the right information, because sometimes they're sent to an experienced hospital with the wrong diagnosis or with some question marks still. So, and there's always a discrepancy in what is the stage and what is the grade. So people mix that, the terms of that mix that up. So I do think it's also very important to give them a clear explanation what the diagnosis exactly is and what stage and what grade the tumor is. And that's also depending on what kind of treatments there are available for these patients, because sometimes they read online different kind of treatments that aren't available for their particular tumor. So it's very important to guide your patient through the right diagnosis with the right kind of options due to treatments. I do think that's also very important information to them.
Wanda, would you like to give a very brief overview of what a stage and grade is?
Well, the stage of the disease it's about the extent of the disease, where it is located, primary tumor only, or is it already metastasized to the lymph nodes, like a stage 3 or a stage 4 to another organ. And sometimes I see that stage 3, they can mix that up with a grade 3. They have so you have gradings. It's about the growth, how fast the tumor grows, and the staging is about the location where it is in your body. So a stage 3 tumor, which is located in the primary tumor and lymph nodes around, it's not the same as a neuroendocrine tumor grade 3. That's about the growing factor of the tumor. So the grading is about grade 1, grade 2 are the slowest growing tumors of the neuroendocrine tumors, and that's grade 3. Or NEC 3, neuroendocrine carcinoma, they're more aggressive tumors. So that's good to know the difference between that.
And you know, patients would have heard that term Ki-67, and that is what's used to determine the grade. So maybe
Yes.
Can somebody explain that to patients?
Well, yeah, I do that. I do explain that, because you have the pathology and then the grading Ki-67, of course, and then I make the scheme with the help of the information that's available from the patient website, information websites, and then I always make a note or a drawing in which grade they are, so they know the terms of the diagnosis, they know the terms of the grade, they know the terms of the stage within one particular drawing. Yes.
Yeah.
So I have a question here in the poll. It's question number 17 about grading. So it fits really well here. So can the grade change during the course of the disease? Maybe Andrea or Anna?
Thank you so much. That's a very good question. We know that the grade can change during the course of the disease, means the tumors that were initially graded as grade 1, means not so aggressive, change their behavior during the course of the disease to a higher grade. Grade 2 or sometimes even grade 3 means they then develop a more aggressive behavior, and clearly they are then also more challenging regarding the treatment. In addition, what we see, if we compare grading within a tumor mass or within a primary tumor, means theoretically a tumor in the pancreas and metastasis in the liver, there could be also some differences. What we see quite often, that the grade could be lower in the primary tumor, again back to what I said, for example, in the pancreas, but higher than in the liver. So also the grading is extremely important and guides our decision regarding treatment and prognosis clearly of a patient. Still, we have to consider all these different possibilities that can occur within the grading system.
And just to say that the grading can only be established with histology, with biopsy.
Yes.
Yeah.
So when a patient's primary or metastasis changes grade, that's changing the Ki-67, how is that detected? Is it purely by some things are happening to the patient and the patient is brought in for another biopsy. Is that the way it's done?
If I may reply to your question, in some patient we see, for example, on imaging that the disease shows a more aggressive type of behavior as expected, and that there are potentially various areas within the manifestation of the disease that show growth compared to others. And then we see sometimes also kind of discrepancies, means different information seen on MRI and PET-CT, as explained by Anna. So these are all the indications that there might be some change in the grade, means potentially another biopsy is required.
Yeah, and perhaps maybe a comment from my side would be for the patients is, particularly in the early days, as you're going through the process of getting a diagnosis, it can be quite overwhelming, the amount of information, the amount of medical terms and language that, is coming across you in thick and fast. It can almost feel like a bit of a freight train. So kind of being prepared going into those meetings with your primary caregiver, or so your oncologist, asking the questions around and being specific around, where is the primary? Has there been any metastasis? What grade are we looking at? And what stage are we looking at? Are good questions to take in, because when you're having those discussions, it can be very overwhelming. So kind of having them written down, making sure you're asking the question and then are comfortable and understand that the responses that you get back, you can clearly kind of understand, because it's very easy to get lost in the medical jargon, particularly in the early days as you're still kind of getting your own knowledge and up to speed.
Yeah, and I think just adding to that, Duncan, it can be very important that you get the information from the relevant sources rather than sort of generic cancer sources, because I think stage 4 for many people in other cancers would seem potentially much more serious than it may be in a patient with a neuroendocrine tumor. So I think it's important to get the information from the neuroendocrine community and your MDT preferably, rather than a sort of generic cancer source of information.
If I may add in this regard, it's also important for patients to know that they can always seek second opinion. This is extremely important, and this possibility is available, and one should not think that he or she might offend the doctor treating a patient. So I can only recommend to go for second opinion, particularly in very challenging or unusual cases.
And how does a patient seek that second opinion, and where do they find the person to give that second opinion? Is it their consulting physician that will then seek out that, or do they come up with an option?
In my opinion, or in my experience, the consultant, the primary consultant who is seeing the patient in the clinic should be the one who can then suggest if a patient seeks for second opinion, and this is not so unusual nowadays. I must say that also we as consultants sometimes want to have opinion of another group of consultants and ask for their opinion. So for the patient, I think the primary consultant seeing the patient in the clinic should be the one who should then also help to get second opinion.
I think also that it's possible to check up the list of centers of excellence of neuroendocrine tumors, the ENETS Center of Excellence in Europe, yes, or in other continents, and reach out, because usually you will find experts in these centers of excellence.
Yeah, I think that's very helpful, because if I can just slightly come back to you, Andrea, I work as both a doctor and as a patient, and you will know that not all of your colleagues are quite as welcoming to a second opinion as you are. And I think sometimes the patient does have to do the donkey work themselves, but I absolutely agree with you that every patient should be entitled to a second opinion, and that the primary doctor involved should not make that more difficult.
And particularly if I am referring to the situation in UK, the patient groups are also able to support a single patient in this regard.
Yes.
So one should be really very open to the approach of second opinion.
Absolutely. Yes,
Yes.
absolutely.
Yeah, please, Mark.
Yeah, there's a question, I think it's question 16, which is in relation to this. There are no net specialists available in my country. Now, they're in the UAE, but can we get remote support from some doctors? And this really also applies across all of Europe and the world, really, about, you know, is there remote support from net specialists, and how can that be engaged?
So I think that most of the centers of excellence of ENETS can help in that way. I know that there are doctors that get questions from patients from other countries and help out. But I don't know, Anna, would you like to step in? What is your experience in this? Do you get patients from abroad that contact you and your center? Or Andrea?
Yeah, again, if I may reply, we have number of patients who contact us from abroad. So there are various ways for this patient. Sometimes the patient emails directly a consultant. They found when Googling, sometimes the patient approach directly the NET center, asking for opinion or asking for consultant. Sometimes we get requests from the patient foundation. And in addition, there are several insurance companies who are also giving advice to patients. So from time to time, we are approached by the insurance company, particularly when patients are outside UK, abroad, and they ask us if we would be able to provide second opinion for their patients. So there are several ways how to do it.
Yes, the same here. We get some referrals from nearby countries that don't have multidisciplinary groups specialized in neuroendocrine tumors, for example, from Cyprus or from Bulgaria. And they also follow all these approaches that Professor FRILLING indicated. So by email, by letters, or by even direct visiting the center.
Can I give just my own personal experience? I was diagnosed by an oncologist who was a non-net specialist, and she had a perspective on how to treat this disease with a wait-and-see approach. But she encouraged me to get a second opinion. It wasn't me looking for it. She said, no, we really should get a second opinion. And she managed to get a second opinion from a net specialist. And he had a totally different approach to the disease and brought in surgery and treatment, proactive treatment. So, you know, my own personal experience, absolutely so beneficial to get a second opinion. And in particular, if it's a non-net specialist that's dealing with you. So highly encourage it.
So I have a couple of, sorry, Anna, please.
Sorry, being from a small country, we have already developed with Professor KALTSAS, who is the leader of our MDT group. We have a big network of physicians, oncologists, endocrine doctors, gastroenterologists who refer directly the patients to us. And we did get a lot of referrals directly through other specialties. So that's once there is an MDT meeting, I think it's quite a good option for the patient, because he may see one doctor at the beginning, but then behind this doctor, there is the whole MDT group, which is most commonly having at least 10 different specialties. So it's a big thing.
And if I may,
there is a question here that asks if there is a list of all the centers of excellence in Europe, and if you go to ENETS homepage, you will find this list. Just to let you know, please, Andrea.
If I may suggest, it's extremely important for the patient that they request copies of their medical files and the reports, particularly if patient is seeking for second opinion or moving to a different place. It's really important and very helpful to have a copy of a medical file in hands, or at least of the most relevant results.
Yeah.
I'd like to comment just with regards to, I think the ENETS website is very helpful in terms of the Center of Excellence for kind of the European countries. I think for any of the patients watching outside of Europe, I would certainly encourage them to have a look at the INCA website and look at the associate members and the patient support groups. And that's often a very good place to start in terms of getting information for MDTs in local countries or NET specialists. So if you're struggling to find those people in your countries, then look for those support groups, because they will be able to point you in the right direction, depending on what country you're in, and even kind of down to your kind of geographic location and city.
Yes, they're very helpful. That's a good suggestion. We in Rotterdam get a lot of referrals for PRT, and in the past we treated a lot of foreign patients, but nowadays their PRT treatment is available more around the world. So, but sometimes you have a referral and the patient even doesn't know that there's a PRT treatment option nearby or within their own country or in the country next to them. So it's very important to then show them the website, or then show them the INCA website to look for information, or sometimes give them the name of the hospital where the treatment is available. And so we can help each other and help the patient not to travel all around the world, but to see for the nearest by care.
There's a question there, 23, about the fact that the ENETS website is in English, and if they don't have English as their natural language, like, and they want to talk or refer their GP or another doctor. So just to say that on the INCA website, there's a trove of information sheets. I think we're at 24 of them now, all translated into 11 different languages. So there is a lot of information out there in other languages, and perhaps check that out to get some information, and that could perhaps be your reference point or your starting point. Can I ask one more question there, which is came up, which I think is a good one? My metastases have not been graded since the biopsy over 5 years ago. Should I seek a new grading from a patient?
So Andrea or Anna, I can start answering. I think it depends. If your disease is stable, nothing has happened, you're stable on your medication, I would not think that would be necessary. But if things are changing, the tumor is starting to grow more quickly, then I think probably a new grading would be really helpful for the physician to be able to know what kind of treatment you might change to. So that would be my suggestion. If everything is stable, you don't need it, but if things start to happen, it could be good to get another grading.
Absolutely agree.
And then we had a quick question here about PRT, and if you have a mix of tumor, how can you know that? And should you get PRT if you don't really know if you have slow growing and fast growing tumors? And I think that it has become more and more, if you are in doubt, if there is an inconsistency between the PET examination and the CT or MRI, we usually say that you should do an FDG PET in addition, because that can tell you if you have tumors that are somatostatin receptor positive and those that are negative. And if you have many negative somatostatin receptor negative tumors, maybe PRT is not the best option. But we know that PRT works even for low grade 3 tumors as well. So
I'm going to throw out one more question that's been sent in. How do you explain discrepancies between MRI images and PET scan? So I suppose why are they showing different things?
Yeah, so there are different modalities. So the PET scan, if you go for the gallium PET scan, shows only lesions that are positive for somatostatin receptors. It's a functional imaging, so to say. while the MRI is a more structural imaging method. So there are different modes, so to say, and that is why you can have discrepancies between the two different methods. It doesn't mean that one is superior over the other. It's just that there are different ways of showing tumors. I would say that's the explanation.
Yeah. One of the ways that it was explained to me, which I found quite simple and quite helpful, was almost to think of it as if, you know, the imaging is being done by a camera with different lenses, and the different lenses give you different views. And so using the different lenses and having additional different views gives you more information, which enables better decision making in terms of what the next step might be in terms of your treatment. So that's a very simplified, kind of dumbed down version, which I found very helpful.
Good.
Thanks, Duncan. I think, you know, we've reached the end of this time for this session. Apologies to anybody who sent in questions that we couldn't answer. We tried to keep everything as generic as possible as well to have a good discussion. Thanks to our speakers and to the panel here for that. I think it was a great discussion. I think we're going to move on to session 2 now. And session 2 is going to be about the patient journey with ADVANCED-NET. We will have 2 patient journeys that have been pre-recorded. We're going to play them now. First one is from Rossana Luciano in Italy, and the second one is from Oliver Merx in Germany. And then we'll follow that with Clinician's Perspective by Emanuel CHRIST. And then we'll come back to another panel discussion about that. So as you're watching this, you know, please feel free to post in your questions, and we'll try and get through as many of them as possible in the question and answer session. So we start session 2 now.
Hello to everyone. My name is Rossana. I am 54 years old. I was born in Caserta, but I am actually living in Rome. I am working as a speech therapist, and I am a patient with a metastatic neuroendocrine cancer. I was diagnosed in 2012 in Niguarda Hospital in Milano, and the diagnosis was neuroendocrine pancreatic cancer, and I have metastasis in my lymph nodes at the time of diagnosis. So I had my first surgery in Niguarda. The surgeons removed the tail of pancreas and some lymph nodes. And after 3 months, we found the metastasis in the liver. And in 2018, I had my second surgery, and the biggest metastasis on the liver was removed. And in these years, I had a period of little remission and a period of progression of my disease. So I'm on actually on sandostatin once a month since 2015, and on everolimus daily since 2021. And I'm now having side effects of treatments. I have diabetes. I'm having a very high level of cholesterol and fats in my blood, and hypertension, and mouth sores, and the mouth sores were very uncomfortable because sometimes I can talk, or I can chew, or I can't swallow properly. And anyway, my quality of life is better now than prior diagnosis period, because I am very suffering. I had abdominal pain, very heavy, before my first surgery. So it's very better now. Actually, my future is a big question mark. I'm really overthinking about it, and it's very stressful. So I'm so trying to live day by day, step by step, and I don't put in nice thing off anymore. And however, I need to plan my daily life. So I'm planning for short and medium period. And it's very strange balance. I have in the end a life day by day, and a normal life with plan like everything, like everyone. And this seems to be working for me, for my mental health. And I have improved my soft skills. So I think now I'm managing the stress more better, and I hope I'll be able to handle better in the future. But in the past, after diagnosis, every little condition, pain back, stomachache, headache, flu, everything's made me think that neuroendocrine wanted a ride in my body with new metastasis spreading away. And for example, when I had a cold and I blew my nose, I had to check my tissue. It's irrational thing, I know. But that's it. For me, it was very easy to over-interpret the symptoms in my mind, that they were a sign, a medical sign. So I had studied my NET. I'm following the scientific literature, the events organized by associations. I'm very into my health. In my opinion, staying very focused and being a very active subject in my care, it's very helpful. And it's possible, I have to say thanks to the associations of physicians and patients and volunteers, because they are teaching me there is a way to be more ethical, like patients. Like a patient, they are switching a very private and personal experience into a collective, plural experience, working to improve early diagnosis and free and KALTSAS for everyone, and especially to find new treatments. We need it. Doctors Francesco Pansuto and Maria Civillo are managing me from Sant'Andrea Hospital in Rome. They are gastroenterologists both, and they work with other specialists in a net medical group. So I'm very lucky. They are very, very focused on my health.
Hello, my name is Oliver Merx. I'm 59 years old. I'm married. I got 2 children, 4 grandchildren, and I got I have had a pancreas tumor, a pancreas NET. This was diagnosed in 2020 after, let's say, a longer patient journey. It was overseen for more than, let's say, 1.5 to 2 years. And the tumor got resected in March 2020. So I'm fully employed today. I work as an e-health expert, so to say, and in the digital area. Your question is very interesting. Today, 3.5 years after resection of the tumor, there are only a few symptoms that I could mention, to be perfectly honest. So most of them are related to a hernia operation in 2021. And there has been regularly abdominal pain since then. But to be perfectly honest, I do not think it is directly related to the NET. And this is important for me because it's some kind of secondary pain, so to say. Yeah. Recently, so 3 months ago, I got an injection because of the new nipple metastases that have appeared. This usually causes abdominal cramps, so to say, for 2 or 3 days after the injection. But after the 3 days, the cramps normally disappear till I get the next injections. And so I would say, to answer your question, I do not have many symptoms directly related to the tumor or to the NET or the liver metastasis. I thought a lot about this question, and to be perfectly honest, I think that might be not that often, but I do not have so many, let's say, symptoms or just the operation. This was the only, let's say, change in my life. The rest is more or less the same like the life I had before. And I think this is not easy to answer the question the way you might expect an answer. So many people would say, okay, I have to do this and I have to do that. Yeah, but as you already know, I have a more or less normal life. So it's hard to explain how I could give tips to someone who feels totally different. So if someone has a mammalian tumor, it's a totally different, let's say, yeah. So with a KI 67 of 7% or so, I have a slow growing tumor. And life seems to be normal for me. And I think this is, it's the news. The news is that my life is more or less the same like the life I had before. So how to express anything else? I do not know how to give any tips to people who have a totally different background, a totally different situation. So people with a more malignant tumor, they have a totally different situation. So my story is, hello, I'm Oliver. I feel fine, although I had an NET tumor. Yeah, and I think the interesting thing for me is that life did not change. It's absolutely the same, besides some very, very small differences. So I get an injection every month or so. Then I got 2-3 days, I got some cramps, and the rest is, well, it's the same life I had before. Yeah. And believe it or not, but it's a fact so far, yeah. So for the past 3 months, I received somatulina autogel injections to block the growth of my liver metastases. And blood is also always taken and analyzed. That's more or less a kind of, let's say, new cure I get. In addition, I get an MRI scan every 3 months, and in future, I expect to have a PET-CT scan every year or so, or maybe every 6 months. Let's wait and see. So because the liver metastases are relatively new, they were diagnosed in April. I do not exactly how this procedure will go on in the near future, but I expect, as I said, I expect PET-CT almost every half a year. Yeah. Last but not least, I have an appointment with my dermatologists every quarter, and that's all. So this is the kind of care I received so far, and it feels good. Yeah. So far, I live a relatively normal life, and I'm happy to say that the disease does not affect my life that much. It really surprised me that life after pancreatic tumor and now with liver metastasis can be so worth living, and let's hope it stays that way. So I do not have many effects, as I already said, and it seems that life is more or less normal. That's maybe unusual, but it's a fact. Yeah. And maybe this is a very good, let's say, answer for all those who won't believe that it's possible, like me. When they diagnosed my tumor, I was not able to imagine that such a, let's say, livable life is possible. And now I know it is.
Thank you very much for these 2 excellent testimonies. They allow me now to go through these stories with a clinical perspective. I'm one of the head of the ENETS Center of Excellence from the University Hospital of Basel, Switzerland. Next slide, please. in particular, what are the characteristic features of neuroendocrine neoplasm, how they are called now like that, and what does a NEN clinician need to manage a patient with NEN in real life? And both patients alluded to that in a very nice way. Next slide. So neuroendocrine neoplasmal tumors, they are characterized by on one side, inappropriate hormone or metabolic secretion. Anna alluded to that. And obviously this needs a treatment which is rather performed by an endocrinologist. On the other hand, it's a cancer, so it's a proliferation and inappropriate control of proliferation. And there we need an oncological therapy. And actually both treatments, they are related to each other. Just now, for the epidemiology, about 1 out of 4 patients has an inappropriate hormone secretion, most often in the context of intestinal neuroendocrine tumor. Both patients did not have a clear symptoms associated with a hormone secretion. So they are on the more frequent case with a primary site in the pancreas. So next slide, please. These are data from the Swiss Neuroendocrine Tumor Registry. This is a prospective registry started in 2009. And you see here the black and the gray samples, and they show clearly that pancreas and intestine are the most frequent primary site of neuroendocrine tumor, as in our patient. Next, we have heard that from Anna, and we heard that also from Oliver. There is a differentiation pattern of neuroendocrine neoplasm. This is related to the proliferation index, so slow proliferation G1, a little bit more aggressive G2, but both are differentiated, and then the rapidly progressive disease with the G3. And you can see the most frequent differentiation is really G1 and G2, as in our patient, Rossana and Oliver. Rossana, she has disease CIT 2012, Oliver CIT 2020. So you can see, so both have a slowly progressive tumor on the whole, which is in our database, but which is also in other places in the world. Next slide. What is the characteristics feature of neuroendocrine neoplasm? Anna alluded to that, and I can just repeat that, and Oliver alluded to that as well. You can see here on the image B, you can see a neuroendocrine tumor, and it's completely black. And Jean-Claude Reuby, he was a researcher. He had a method to look at somatostatin receptors. Receptors is just like a keyhole, and it's only one key which goes into this keyhole. And you can see on a neuroendocrine tumor, there's a homogeneously distributed pattern of a lot of these receptors, of these keyholes, over the whole tumor. On the image E, there's a breast cancer. And you can also see there some of these keyholes, but it's not homogeneously distributed, and it's only in a pattern or at some places. So, and this is an absolutely characteristic finding of neuroendocrine tumors, and it is not available for other tumors. Now, next slide. Now, what is the significance of these receptors, of these keyholes? You have here as a tumor cell in the middle with a nucleus, and you have this keyhole or this receptor in orange. And you can, on the one side, you can find a ligand, a key, which goes exactly in these keyholes. And this is the octreotide. And if you link these molecules to a positron emitter like gallium, And if you combine that with a normal CT scan, then you can visualize everywhere in humans, not in the tumor tissue, as Jean-Claude Reuby did, but really in humans, where these receptors are and where the tumor is. The second important significance is you can use that for treatment. And you have heard from both patients that they have somatostatin analogs, so injection once a month. And this is nothing else than also octreotide, which also goes to these keyhole, to these receptors, and it blocks and stabilizes the proliferation on one side or the secretion. Secondly, this treatment, which has also been already alluded to, this peptide receptor radionuclear therapy, uses the same receptor for treatment. So it's octreotide, like for diagnosis, which is linked to a radioisotope that disrupts or kills the tumor cells. So these receptors are extremely important for diagnosis and for treatment for patients with neuroendocrine neoplasm. Next. So this is just an example. Anna showed a similar. On the left side, you see a positron emission tomography. So everywhere where the black spots are, there are these receptors. There is tumor, you can see in this case in the liver, and some lymph nodes in the belly. And if you fuse now this PET with a normal computer tomogram, you can see where these spots are. And you can see here some lymph nodes and some spots in the liver. And this is the usual and the state of the art of imaging in neuroendocrine tumor. The whole procedure takes about 2 hours, and this is much more convenient than the previous way with Octrescan, which lasted more than a day. Next slide. So this is just a scheme for the treatment of neuroendocrine neoplasm when they are differentiated. We heard from Rossana and Oliver, they had surgery. They had surgery at the beginning, and we know that surgery is still the only treatment which can cure neuroendocrine tumors. Unfortunately, especially in non-symptomatic, non-secreting neuroendocrine tumors, about half are already metastatic when the diagnosis is established. A second treatment is local ablative. This is a destruction of the tumor, mainly in the liver, with a very directed treatment through the vessels which go to the metastasis. Then a third, we have drugs, and we heard about that. We heard about 2 drugs, somatostatin analogs, and Oliver nicely alluded to the main side effect of this drug, which usually vanishes with time, not always, but vanishes with time. And Rossana, she alluded to the targeted therapy, everolimus, which is also used. And the last thing, the last method we have available is exactly this in vivo radiotherapy everywhere where there is a keyhole called somatostatin receptor, using mainly lutetium. Now, which methodology is administered or suggested, this is not always established and depends sometimes also on the availability. Next slide. And now this MDT, I think this is the most important step in the whole business. And Rossana, she alluded to that in her testimony. You can see this is our meeting we have in Basel. We have every 2 weeks, we have a meeting. And there, next slide, the surgeon, the king is there, obviously. The endocrinologist, he hides behind. The pathologist is extremely important because he tells us the differentiations. The oncologist is important and the gastroenterologist is important. So it's crucial, and this was already mentioned, that all patients at some stage, ideally at the beginning, and when there is again progression, is discussed at an MDT. I think this is important, but what you also know now from this testimony, a neuroendocrine tumor can be called in a lot of cases chronic diseases. We have treatment available to stabilize the disease. We have only surgery to cure the disease. Thank you very much.
So, thank you, Manuel, for that presentation, and thanks so much to the patients who very kindly shared their stories with us, from Rossana and Oliver. And we're going to open up now to a panel discussion on this session. Let's see if does anybody have any comments to make from what we've heard so far.
Would like to, can I start?
Please.
I would like to congratulate the two patients. I felt very nice to hear their stories, and they transmitted a large amount of power, I think, to everyone who listened to them, even if even to individuals like me, who I am a doctor. I felt that they made an exemplary turn in their life. They got a lot of power from within themselves, but also I felt how important it is, the patient focus group. And this is important to keep it in mind when we are doctors and we treat these patients, to refer the patients to patient support groups. I felt that any patient who could listen to these two stories would get a lot of power and a lot of optimism, and a lot of good points to endorse and follow in their own lives. And again, I would like to congratulate the patients for being so nicely in presenting their story and giving so much detail about the way they got focused, more focused, and in their everyday life. Thank you very much.
Yeah. I was going to say, I absolutely love the last slide, Emanuel. I think from a patient's point of view, surrounded by all these dwarfs, it's we should think of ourselves as Snow White, for whom all these little dwarfs are scuttling around trying to help us. With regards to the patient stories, of course, they're two stories amongst hundreds, if not thousands, of differing stories. But I think both of them illustrated, interestingly, that persisting symptoms are often associated with the treatment rather than the disease. And Rossana mentioned the mouth sores, which I presume were related to her targeted therapy, and Oliver, the symptoms he got for a few days after the somatostatin analog. And I think that's something for patients to get their head round, that and can be quite difficult psychologically. And I think Rossana sort of intimated this, that there is the potential to worry that every subsequent symptom that you experience may be related to a progression or a worsening of the illness. And I think she illustrated just how important psychological support is, for these patients. And thank God that many of our organizations that exist internationally do provide that excellent support. And I would want to encourage everybody to access that if they are struggling from a psychological point of view.
I would also like to add something to that. First of all, I would like to thank Rossana and Oliver for sharing their story, very illustrated. And it also points out that there's a really difference in patients. And I think it's also good that Oliver showed his story with also positive things, that he's a working person. There are a lot of patients we have in our hospital who still have a good quality of life and still want to be available at work and give their energy to the society. And it's also good that these stories are shared, because sometimes those people looking for similar situations, and most of the time the stories shared online or platforms are more worst case scenarios than the ones who are still be able to work. So I also do think that's good to highlight these patients, that they can see there can be a different kind of story as well. And Rosanna's story showed indeed how important psychosocial care is in living with the disease every day, and what she said, living day by day. And what I find difficult is sometimes to find a rehabilitation program, because most of the rehabilitation programs, and I don't know if that's for every country the same, are focused on a patient who had cancer and survived cancer. But it's more difficult to find some program for patients that living with a more chronic situation of cancer and having different kind of treatments every time. So hopefully this will be more easy in the future. I hope so.
I think there's another aspect which is in my experience quite important, that at the beginning you have to clearly define and explain what an EN or a NET is, and that's not an explosive tumor which will increase in size within days or weeks. And the consequence of that, and in my experience, this is always quite helpful, you can tell the patient, we have time to find the best solution and the best treatment option for you in your situation. We have time to discuss that really at the MDT. And when you say that at the very beginning, I think then it becomes much easier, because when they come the first time to me, they say to me, I have pancreas cancer, and everybody knows what pancreas cancer means. And I think this timeline, that we have time to explore and find the best solution, is critical.
I do think that.
I think with a rare disease like this, really it's fellow patients that can really help you on your journey. And I think I would really encourage our patients to seek out patient support groups in their locality, because you know, as a patient, when you're told you have this disease and you're told it's cancer, you don't know anything about it, and like you said, Emanuel, there, like, you know, if it's pancreatic, you think all of the bad things that goes with that. But when you meet other patients who are on the same journey, you know, we're at different stages, but there's some wonderful supports to be had from sharing your journey with those other patients and hearing their supports. They understand what you're going through and you understand what they're going through, and that really is great support. If there is no support in your territory, perhaps seek just through your hospitals, if it's possible, to seek other patients. And as INCA, we absolutely will help and encourage you to set up patient support groups. But I also want to go back to the patient stories, and you know, they were positive stories that were shared. I think, as we've said here, the psychosocial aspect of living with this disease is not necessarily well sort of supported in society, and we need to really recognize that patients can struggle with that, you know, having to live with this, and particularly coming up to scans and consultations. You know, has things changed? Has it progressed? And you know, and it can be difficult. Oliver described a very positive attitude to living with disease, dealing with his symptoms. But, you know, as we've said here, that there are other patients that really struggle and have problems, have physical problems with the disease, and it has a big impact on their quality of life. And, you know, they should know as well that, you know, it happens, and seek out help and support in trying to deal with that.
Yeah, no, I was going to say, Mark, as you know, I wear two hats. I'm both a patient and also a doctor as well, a primary care doctor. And I think not only do patients need to consult organisations for support, but many patients that I've spoken to find it very difficult to have good conversations with particularly their primary care doctors, but sometimes hospital doctors who are also relatively, if I can use the word, ignorant of the consequences of a diagnosis of neuroendocrine tumor and managing a long-term condition that isn't something like lung disease or asthma or diabetes. So I think I would want to encourage doctors to access the information that's available as well in these support groups.
I would also like to add that being me as a nurse, but as a nurse, you play also a big role in this support for patients in the hospital. And that's why I also think that a nurse should be involved with the MDT, because then they know what the patient goes through and needs to undergo in medical terms. And I think as a nurse, you can explain it more easy to the patients. You're much easier accessible for the patients. So I do think nurses should be also included in this MDT to support the patient at the best way.
You can be grumpy in terms of the seven dwarfs, if you like, or that.
And I just speak as a patient as well. I speak as a patient, and I also run some UK support groups. And one of the areas that I think perhaps we've missed discussing here is the level of fatigue. Patients constantly report the fatigue and how difficult it is to live with fatigue and to manage fatigue when they want to do the rest of their daily lives. And as Wanda said, it's very, very much like living with a chronic condition, and you don't really have any choice with it. You have to find a way to manage that level of the fatigue that comes both with the cancer diagnosis and with the treatment options. And that's a really massive factor for patients.
Yeah, and maybe by extension from that, I think what we're also talking about here with the patient support groups is the sense of community. And I think that's a really important aspect of living with NETS, is having a community who understand and can relate to what the patients are going through. And I think being part of a support group does provide that sense of community, of where it's a safe space to kind of share where you are and what you're struggling with, or what might be going well, or whatever the case is. And I think listening to other people's stories also provides a sense of perspective. So people who, might be, when you hear other people's stories, it might give you a slightly different perspective on your own disease and the impact that it's having on you as an individual, which may be very helpful. And I've certainly kind of benefited from hearing other people's stories. And in turn, I found it very rewarding to share my journey with other newly diagnosed people and supporting them kind of through those initial stages of all of the uncertainty, the doubts, the trauma, and just kind of sharing my experience and saying, look, I'm not an expert, but I can share my experience. And if there's anything that you can take from this that might be helpful, then please do that. But I do feel like kind of belonging to a community is an important kind of support or crutch in living with NETS. So just reiterating some of the conversations around joining these support groups, and you can be a very active participant, or you can be a very silent participant, and you can really just kind of listen in and just get a little bit more knowledge and understand a bit more about the disease. And then when you're comfortable to share, you can start slowly initially, and then eventually you might become more comfortable to share more. And as you kind of grow in your own personal journey, I think that helps with a lot of the integration of, where you are psychologically with your disease and wherever you are on the journey.
Thanks, Duncan. I think that we've really gone a lot of time on this session, and we haven't asked any of the questions, so we have quite a few in. So I'm going to throw a couple out, and we'll take a few minutes extra on this session. But one of the questions, 37, analogs can stop working at some point. Does this mean the body's getting used to that drug? Does it mean the cancer is getting more aggressive? So anybody, any comments on that?
So maybe I can jump in on that one. I've kind of had recent experience of this. And again, I'm not medical, so I'll defer to the medical people if they want to comment. But, I think when there is disease progression and tumor cells that are well differentiated become de-differentiated, they start to kind of lose their shape. And those SSA receptors on the cells are kind of broken down. Then some of the treatments, such as the PRT, are no longer effective. And that's when you move into a different kind of therapy, such as chemo, which is less targeted, but targets all the kind of fast-growing cells, and it might be those de-differentiated ones. So I think the short answer is, as those cells change in nature and become de-differentiated, the somatostatin analogs become less effective. That's kind of my patient view, but perhaps someone might want to give a medical.
Yeah, I can support that. This is true. And Andrea FRILLING, she mentioned that in the session before, that tumors, they can behave differently going along with time. So this can be, and this is exactly every time when there is progression, then you have to discuss the next step and the next method again. And then at an MDT, this is the time for that.
I think maybe we could have one more clarification, because we have quite a few questions in the chat about the difference between neuroendocrine tumor and neuroendocrine carcinoma. And could you just say very quickly, what is the difference?
Shall I?
Yes.
Okay. Carcinoma, you have seen, these are rare patients with carcinoma. So it's rapidly proliferating neuroendocrine tumor or carcinoma, which we have heard about Ki-67 of 7. Now they are usually the carcinoma over 50%. So you can imagine the proliferation is much more rapid. And usually they lose their keyholes, they lose the somatostatin receptors. I think these are the key features of the carcinoma, and they need different treatment. The reason for that the biology behind these tumors are different from the other neuroendocrine tumors.
And the tumors then have a lower Ki-67, Emanuel, yes?
That they have a higher Ki-67 over 50. The tumors.
But the neuroendocrine tumors,
they have a lower, yeah.
Mm.
And then you also talked about the term neuroendocrine neoplasms. Just for patients that don't know what that means, what is
it's
that?
It's exactly the same thing that the tumor. It's the new terminology, because I think that behind that is the neoplasia, is that we want a little bit say that they are not tumors, not cancer, like the G3. They are more benign, despite the fact that they can proliferate and they can behave as cancer do.
Yes, and I think that the neuroendocrine neoplasias contain both the neuroendocrine tumors and the neuroendocrine carcinomas in sort of a common name. But I think now, if we would like to thank the panel for this very, very interesting discussion, and thank you to the patients for sharing their stories. I think this was very helpful and very nice of you to do so. And it's time for us to move on to the next session. And this is about an emerging area, the genetics of thoracic and digestive nets. And I think this is something that we are going to learn more and more about in the future. But I now welcome Professor Gregory KALTSAS to introduce the subject to us. So please.
Good afternoon, everybody. I'd like to thank the organizers for this kind invitation. It's a big pleasure for me to be among friends, physicians, advocates, patients, and try and put together the genetics in the thoracic and digestive neuroendocrine tumors. Next slide, please. So in this slide, you can see what are the causes of neoplasias, which encompass, as Professor JANSON said, neuroendocrine tumors as well. So we have tumors that they are inherited. And when we inherit it, there's a gene mutation that happens in all the tumor cells and in the body as well. And these are inherited into other family members. So these members are at increased risk of developing the neoplasia. This is about 5 to 10% of all cancers, and this accounts for neuroendocrine tumors as well. Then we have the familiar neoplasms, which there is no specific gene and defect that accounts for that, but they have an increased existence within the family members of the same family. And in this does not account very much for neuroendocrine tumors. And then we have the sporadic tumors, which is the majority of the neuroendocrine tumors. And in these cases, there are no genetic defects or genetic alterations that they occur in these tumors. And there may be some other things that they may impose the development of the tumors, and they could be also as environmental factors. So the majority of neuroendocrine tumors are sporadic, which means that they are not transmitted, no other family members are affected, and genetic alterations, if any, are only in the tumor. And the inherited neuroendocrine tumors, which means that other family members are affected, they are transmitted, and the genetic alterations, they occur in all tumor, in all cells of the body, and they circulate in the blood. And the ones that Dr. Christ mentioned, the ones that the most common, and I'm going to emphasize on that, are the ones that they come from the gastrointestinal system, and they are the pancreas and the small bowel neuroendocrine tumors, and the ones that originate from the lung. Next slide, please. I'd just like to elaborate a little bit further the inherited syndromes in neuroendocrine tumors. And you can see on the left of the slide a mode of inheritance. And you can see two family members, the father who is affected and the mother who is not affected. And every one of them transfers one of the childs with one gene from its own. So every child has one gene from the father and one gene from the mother. So the father is the affected gene. And this mode of inheritance, it's called autosomal dominant of inheritance, which means that the one from the mother functions, but the one of the father does not function. So if the child gets the one of the father that does not function, it's going to develop the disease. And if it gets the one that is okay and is not functioning, they're not going to develop the disease. So it's about 50% chance of developing the disease. And this is what happens in the inherited syndromes in neuroendocrine tumors. And usually what happens, the gene that is affected is a loss of function gene, which means that it does not produce a protein when it's present, it affects the cell cycles and inhibits the proliferation of the cells. So this gene is affected and the protein is not there, then the cells proliferate and then you have the disease. On the other part of the slides, you can see the most common inherited syndromes in neuroendocrine tumors. The first one is the multiple endocrine neoplasia type 1, which is about 1 out of 30,000. And this one involves pancreatic and thoracic neuroendocrine tumors. And these are the most common and the most affected patients with this syndrome, because pancreatic neuroendocrine tumors, they account for about 50 to 80%, and the thoracic ones about 10 to 20%. The other ones are not very common. You have the MEN1-4, then you have the von Hippel-Lindau, which have pancreatic tumors between 9 and 70%, and the neurofibrosis one and the tuberous sclerosis one are not so common. Can I have the next slide, please? However, I mentioned that the majority of the neuroendocrine tumors are sporadic. And I mentioned that I'm going to discuss the pancreatic ones, the lung ones, and the small bowel ones. And when it means that they are sporadic, as I mentioned, there may be mutations, but these mutations and gene involvement, they are only in the tumor that develops and they're not in any other cells of the body. So in cases that we have a pancreatic neuroendocrine tumors, you can see that there are some mutations, MEN1, ATRX, DAX, that account for about 40% and maybe in the mTOR pathway. And then they accumulate, and then you still get tumors that they are well differentiated, which means that they look alike the cell of origin, but then according to the proliferation rate, they can be not very aggressive, like G1 or G2, but then if you accumulate more mutations, only the tumor that they develop, then they can be more aggressive, like G3. However, if you get different mutations, like the ones shown in the middle, you can get the poorly differentiated neuroendocrine tumors, which now are denoted as neuroendocrine carcinomas, but they're very aggressive, and they look like the very aggressive pancreatic adenocarcinoma. And as you can see, the neuroendocrine tumors, they don't have as much mutations as the pancreatic adenocarcinomas, and that's why they behave in a better way and they are less malignant. Can I have the next slide, please? I also mentioned that we have the lung neuroendocrine tumors, which are relatively common as well. And as you can see, these tumors are called carcinoid tumors of the lung, and the majority of them are the typical carcinoids, which are low grade, and they look alike the cell of origin. And you have the atypical ones, which are well differentiated, which means that they look like the tissue of origin, but they're a little bit more aggressive. And hopefully the typical ones are much more common than the atypical ones. So if you look at the other part of the slide, you can see that the ones that they are well differentiated, the typical and the atypical, they have a different mutation pattern from the ones that they behave very, very aggressively, like the carcinoma ones. And they can distinguish their presence with these mutations. But then as they accumulate more mutations, then they become very, very aggressive. But this is not usually what happens, because only the ones that are atypical carcinoids, they can behave in a more aggressive pattern. Can I have the next slide, please? And I also mentioned the small bowel neuroendocrine tumors. And in this case, we don't have that many mutations that they are in the chromosomes of these tumors, but we do know that there can be some genetic alterations that they affect the way that the genes are expressing themselves in real life. And these are called epigenetic changes. And we have very, very complex ways in order to try and identify these mutations and genetic alterations. Can I have the next slide, please? So the majority of the neuroendocrine tumors are sporadic, which means that they're not inherited. And therefore, there may be specific genetic alterations in the tumor that they may have prognostic significance, and they could be of therapeutic implication. And about 10% of the neuroendocrine tumors, they are inherited because we have specific genetic changes and we know the genes that are involved. Therefore, it's very important to perform relevant family screening to identify the members that harbor these mutations, and they are very risky developing the disease. And as you can see in the other part of the slide, what are we doing at the moment if we don't know the specific genetic alteration and the biomarker that we can identify? We treat these patients with the same regimens. And because we cannot identify the patients that they will be more beneficial to this treatment, we can have efficiency, we can have no effect, and we can have a lot of adverse effects. However, if we know the gene that is involved, and this can be targeted by specific medication, then we can have a lot of efficiency and not side effects. Thank you very much for your attention, and I'm happy to answer any questions.
Thank you so much, Gregory, for this fantastic introduction to this very difficult subject. I can start out with asking a question. So, do you think that we should tell our patients to have the tumor tested with next generation sequencing, or do you think this is something that will come later on?
I think that in cases that we have an inherited syndrome, then we do know that we can identify the mutation, and the majority of the cases, the mutation can be identified with conventional techniques, but there are some cases that the next generation sequence may be needed to identify the minority of the cases where we cannot identify the gene. But in general, to perform next generation sequence to identify potential mutations that they could be eligible to be treated with a specific drug that we don't know if it is existing at the moment, I think it's a matter of further research, and we will accumulate data in the future.
Yes, there is a lot of questions also about when to get genetic counseling. So what would you answer then?
Okay, I mean, as I mentioned, we have the inherited syndromes that are about 5 to 10% of the neuroendocrine tumors. The way to identify these syndromes, and I'm mainly focusing on MEN1, which is the most common one because it involves the pancreatic neuroendocrine tumors and the thoracic neuroendocrine tumors. The way to identify this syndrome is either clinical, if we have specific organs that are involved, including the pancreas. And then if you see there is a trait in the family tree, as I showed you, because any other members, they may be affected. So if a patient that comes from a family that has one of these this syndrome and has one organ that we know that is involved in this syndrome, then we do know that it has a syndrome. And we do know that it's going to carry the mutation. And of course, if we have a family that has the syndrome, then we do know the mutation. So if a patient has not developed the syndrome yet, then we can screen for the mutation. And as I mentioned, if somebody has the mutation in the family, it's not absolutely necessary that it will convey the pathological gene to all the members of the family. It's about 50%. So if we screen this patient that comes from a family, let's say with MEN1, then 50% chances to have the mutation, which probably going to develop some tumors of the syndrome, but 50% if they don't have the mutations, they have the same chance of developing the syndrome as the normal population.
Thank you. I have another question here, maybe for Anja. So if you are diagnosed then with an inherited syndrome, does that affect how your tumor is treated in any way?
Yeah, it affects the person, him or herself, but also, of course, the family. As you pointed out, that there's a 50% chance or a risk for the daughters and sons that they may be affected, and they should be if they are affected, have a surveillance, of course. But also for the person where it was first diagnosed, management has changed, because we have to have in mind that these patients usually have more than just one tumor lesion, for example, in the pancreas, but they have often multiple endocrine tumors, often benign. But we have to take this into consideration. For example, they often have a hyperfunction of the parathyroid, so they get high calcium levels in the blood, and we have to have this treated most times surgically, but maybe also with medication. And there's a risk for also lesions in the hypophysis, and so they have to get an MRI of the skull, which is not a routine diagnosis in our patients with NETs otherwise. So, and there's differences in the prognosis, for example, for patients who suffer from gastrinoma. They're usually relatively benign in the behavior if it's associated with a genetic syndrome, MEN1. So it also may affect how the management is done. And of course, for example, usually if there's a pancreatic NET, which is more than 2 centimeters in size, you will go for operation. But a patient with MEN, there may be multiple lesions, and so you have to have this the whole story on your image and decide which really is the one I have to treat, if there's dynamic or if they do secrete hormones, for example. So I think management is influenced and should be really done by experts, because it's very complex with our MEN patients.
Thank you. Kate,
can I throw a question out there, Eva? Sorry. So question 48 is about a patient who was diagnosed with a single primary site of a NET. And then years later, their sister's diagnosed with another NET. But yet they were never diagnosed as having genetic NETs. I mean, is that an indicator that they should be tested? Should that happen automatically, or is this just pure coincidence?
Sorry. Yeah.
Go
ahead, Greg.
Okay. I'm sorry, Anya. As I showed you, I made distinctions, the inherited, the familiar, and the sporadic. So the familiar is that when you have tumors, and in this case, neuroendocrine tumors, that they develop in the same family, and but apparently no specific gene defect is identified. And this is not very common with neuroendocrine tumors. There is a family in Sweden with small bowel neuroendocrine NETs, neuroendocrine tumors, that they have this trait. And I'm sure that Eva knows better than me, because I think that it has been identified in Uppsala. But as far as I know, there are not many familiar neuroendocrine tumor syndromes in the entity of neuroendocrine tumors. There are in other neuroendocrine tumors, from the ones that they arise from the thyroid, let's say, where we do know there that we have a familiar medullary thyroid carcinoma, but we do know there that they harbor specific mutations. So for the familiar ones, we can do this complex testing and next generation sequence, as Eva said, in order to try and identify potential genes. But it's not very common in neuroendocrine tumors of the gastrointestinal system and of the thorax.
Gregory, can I ask you a question? Thank you for your presentation. I've got a question that came in from a patient, a young man, fit and well, but diagnosed 10 years ago with typical lung carcinoid. He has done 4 cycles of PRRT 4 years ago, but is wondering what's next because he's got a heavy burden of disease and a recent liver MRI has just shown progression. Has the panel got a view on what he might do next? As lung, he's accessed PRRT already.
So it's a typical carcinoid that has this
heavy burden.
Yeah, this is not a very common clinical course for a typical carcinoid because they're usually, very well differentiated. And so the first thing I would like to think is if I could question the diagnosis and the histopathological diagnosis, if it's correct. If the diagnosis is correct and it's a typical carcinoid, this is not the very, very likely clinical course, but we do know that typical carcinoids, that they're more than 3 centimeters, they can behave a little bit more aggressively, particularly if they don't express this marker that I showed you, the OTP one. And then we have to consider other lines of treatment down the algorithm. And PRRT is high up in the management, but then after that, if it proceeds and further increases the tumor burden, then we can consider other means like chemotherapy or molecular targeted therapy. I think in this case, chemotherapy is probably the most sensible procedure.
Okay, thank you.
May I add, I think we really should look not only on the histology, that could also change over time, but where the progression is. If it's only the liver, we also could work with liver-directed treatment if the progression is restricted to the liver. And of course, we have everolimus as option. And if it's 4 years that PRRT was done, we also could go for retreatment if the somatostatin expression is high, and so there are some options, and I think we have to check whether what is the PET-CT scans showing, and about the somatostatin receptors, what are is there no renal insufficiency, and the bone marrow, of course, has to be okay. And we also should have a look at the dynamic. So if it's slowly progressive, I think we could go for PRRT or everolimus. If it's rapidly growing, we should rather use chemo. But I think that's has also to be taken into consideration.
Thank you.
Can I just add a comment just on the PRRT? One thing that was interesting for me to learn through our patient group is we have someone here in South Africa who has had 12 rounds of PRRT over a number of years. I've personally had 7 rounds in 2 years. So it does appear that, you know, the trend seems to be that actually, depending on the patient's health and specific certain circumstances, that PRRT is a repeatable treatment that can be done. And then the second comment that I just wanted to make around the genetics and the genetic counseling, and again, just talking from my experience, I had quite a lot of anxiety and was undecided whether to go for the genetic testing. I've got 2 young daughters, and, you know, one of my primary concerns was whether they were at risk. And I went and spoke to a genetic counselor, and they provided a whole lot of information and asked a lot of questions that I actually hadn't even thought about, including, you know, the possibility of the genetic testing identifying other things that are kind of non-NET related that you have to take in consideration when you do the testing. And I actually kind of sat with that information for about 6 months just to kind of process it and decide on the best way forward. And ultimately, for me, it was about, you know, information and knowledge is helpful, and it's better to know these things. And although there was a part of me that just kind of was not quite ready to go there and do the testing, I think when I did it, it was incredibly helpful. Fortunately, the outcome was positive, which did make it easier. But, you know, if I did carry the genes, then that would inform kind of the next steps with regards to testing other family members. And the final thing that I just want to share, which was also interesting for me, and I don't know whether this is a global standard or if this is just purely in South Africa, but unless there is a specific medical motivation for testing children, you can't actually do a genetic test in South Africa unless you are 18 years of age, because it is not actually even the parent's choice to do the test. It is down to the individual. But I think that might be a South African specific law. I'm not sure.
So I have another question here from a patient who is 50-year-old female who has been operated for a atypical lung net, and there was a identified subcarinal lymph node on gallium PET after the operation, which was thought not to be possible to operate. And this operation, the primary operation, was 1.5 years ago, and she chose to continue with just surveillance, but is now wondering, should some treatment maybe be started? So she would like to hear the panel's opinion about a patient with an atypical lung net with a lymph node metastasis. What would be your suggestion?
I think we should look at the images. If we have 1.5 years of surveillance at the moment, we can see whether the lymph nodes grows in that time. So if there's no development, I think the person's doing fine, I think there's no need. Usually the atypical ones rather grow within 1 year or so. So I would suspect that there might be growth. And if so, I would have a look on the histology again and on the dynamic. And if there's only small growth and the receptors are there, it was told this is quite often, to be honest, in the lung situation, the somatostatin receptors are often not that highly expressed as we see it from the digestive neuroendocrine tumors. But if the receptors are there, there's only a slow growth, although we have no formal label for somatostatin analogs for lung net patients. I would go for SSA because there are only very few side effects, and so you can have a rather normal life. If there's more progression, we could think about everolimus or even chemo if it's very aggressive, or if it's localized in a higher proliferation rate. I would also discuss with my radiation expert whether really localized radiation could be an opportunity in this case, if it's not, it's just a lymph node and not widespread disease.
Can I just add something on that? I mean, she's a young patient with a single lesion, isn't she? And a lymph node only.
Yes, but it was difficult to operate again because of the previous operation of the primary tumor, as far as I understand.
Yes.
Okay, and I mean, it's very important to look at the histopathology and the dynamics, because we do know there that atypical carcinoids, particularly the ones that have a little bit more mitosis and Ki67, they can be very, very unpredictable in their behavior, and later on they can develop the metastatic disease. So I think that usually we don't, as far as I know, we don't try to irradiate these cases because we don't have any hard data about that, and this precludes a further operation. But if an operation is not desirable, then I would discuss it more extensively, the MDT with radiotherapists, to see if this is an option to try and control the disease to avoid any further recurrence.
Yes, thank you.
I totally agree. You should try to, for a second opinion, whether it really is not possible to operate on. If it's only one lymph node, I'm not a surgeon, so I can't really give a good advice regarding this. But I think an expert thoracic surgeon should be ask for a second opinion, whether, because there's a situation where you usually go for curative treatment, and so I would try to find a thoracic surgeon and ask again, is it really that difficult or impossible to resect if it's just a single lymph node? I totally agree with Greg there.
Can we bring Wendy in and just talk a little bit about counselling on genetics with families? And, you know, I particularly thought Duncan's point about parents often want to get their children tested, but testing is not available for children. And, you know, is this a good idea, bad idea? And Wendy, what do you have to say about helping patients with, you know, on their journey with this?
Well, I think one of the things I wanted to talk about, I'm sorry, I can't seem to get my camera to be working, but one of the things I wanted to talk about is also when you've got people with genetic syndromes and they're diagnosed at a young age, and realizing and helping them to come to terms with the fact that they may have then just lost a lot of their plans for the future, where they might have thought about growing up, having a family, and of course being diagnosed with a genetic disorder that can bring up cancer is quite difficult for them to then think about. I think once you've already got children, of course, you're then worried about whether your children do have inherited the gene, and there can be a lot of problems with things like guilt that come along with that. What have you subjected your children to? But I think for the younger people that haven't had a family yet, there's a lot to be done there. So I think it's just really important to recognize that, as well as the uncertainty that goes along with cancer and worrying about early death, the patients with genetic forms of the disease have other more specific needs with regards to, you know, or different needs with regards to thinking about a loss of the future that they envisioned for themselves.
Thanks so much, Wendy. Sorry, Eva, go ahead.
I think maybe we are actually running out of time for this discussion. So I think that we should thank all the participants here for good questions and good answers, this difficult subject. And then I hand over to you, Mark.
Thanks, Eva. So we're going to start session 4 now, which is about what is coming down the tracks. And we're going to have some joint presentation by Stefano Pertelli from Italy about local treatments, and Hans Hofland from the Netherlands about systemic treatments. And then we'll move into a panel discussion about what's happening and coming down the track. So over to you. Thank you.
Thank you, Mark. Good morning, everybody. It's a great pleasure for me to be here today and in this important and significant day. So I'm a surgeon, and I will give you a brief overview about the local treatment for neuroendocrine tumors. So the next slide, please. Surgery is definitely the most used local treatments for neuroendocrine tumor. It is used for lung net, JEP-net, liver metastasis. But we have also other possible local treatments, including endoscopic resection. This is particularly a good option for gastroduodenal neuroendocrine tumor and colorectal neuroendocrine tumor. Radiofrequency ablation is definitely a good option for a small liver metastasis, and is gaining acceptance also for specific selected cases of small functioning pancreatic neuroendocrine tumor, especially when there are contraindications for major surgery. And finally, chemoradioembolization, again, an effective treatment, especially for liver metastasis. The next, please. The aims of local treatment are basically two. The first is to be radical, and in this case, we want to achieve the cure of the disease. The second aim is palliative, and in this case, we want to control the disease, both in terms of symptoms and in terms of progression. And of course, this is a type of local treatment that applies in advanced disease. Next, please. Surgery is probably the most important radical treatment, and is definitely the only treatment that can achieve the cure of a localized neuroendocrine tumor. But don't forget that we are now assisting to an incredible increasing in the number of very small and asymptomatic neuroendocrine tumor, like a small pancreatic net or small gastric or rectal net. In this case, surgery is usually avoided in favor of a wait-and-see approach, especially for pancreatic net, or endoscopic resection for GI net. But also when surgery is indicated, we have to consider carefully a lot of factors before going to the operating theater. These factors include patient status, the comorbidities of a patient, the age of a patient, and also the patient's expectations from surgery, but also some characteristics of the tumor, and of course the risk of specific operation. We know that the range of operations for neuroendocrine tumor is very wide, so we have very difficult and risky operation and less risky operation. Next, please. The bulking surgery is a particular type of surgery that is used quite frequently in patients with neuroendocrine tumor, especially those with a primary tumor and liver metastasis. The aim of the bulking surgery is try to reduce the burden of disease. In other terms, the aim is to reduce the number of lesions. The next, please. And to leave just a few lesions. The next, please. The aims of the bulking treatments are basically three. The first is to relieve symptoms. This is particularly important in the presence of functioning neuroendocrine tumor with producing a specific hormone, or in the presence of tumor-related symptoms like intestinal obstruction for small bowel net. But the bulking treatment can also increase the chance that the anti-tumoral therapy will be effective. We have very good evidence that demonstrate how to reduce the burden of the disease with the bulking surgery or the bulking treatment can improve the efficacy of systemic therapy like PRRT or chemotherapy. And finally, the aim is to help patients live longer. And in this setting, the bulking surgery can improve survival. But in the case of focal progression, can also allow patients to continue their existing systemic therapy. Next, please. So just four take-home messages. Local treatment for neuroendocrine tumor include many options. Surgery is definitely the most used and probably the most effective local treatments. These type of treatment are definitely preferred treatment for localized neuroendocrine tumor. But keep in mind that for small asymptomatic neuroendocrine tumor, a conservative approach is often used. It can be a wait-and-see approach or endoscopic approach. And finally, a combination of different local treatments like surgery, RFA, or embolization is very effective in patients with advanced neuroendocrine tumor. But here, keep in mind that the surgeon is not the only actor. All these indications should be always shared in a multidisciplinary setting. Thank you very much for your attention.
Good afternoon, and thank you for inviting me and organizing this excellent webinar. My name is Hans Hofland, and I'm the head of the ENETS Center at the Russell Medical Center. Next slide, please. So unfortunately, still 40% of patients with a NEN present with metastasis. So this is in advanced stages. So we still need systemic therapies for those patients, but also other patients that have been curatively treated in the past might present with metastasis in the future and need palliative treatment because they cannot be cured. And we have several options that have been introduced in the past few decades. From the 80s, we have treatments like chemotherapy, interferon, and octreotide. But especially the last 15 years, we've seen several new systemic treatments available for NEN patients. These include sunitinib, everolimus, lanreotide, PRT, as discussed before, but also telotrestat specific for complaints within the carcinoid syndrome. So we have, compared to 20 years ago, many new options. Next slide. And we also see that this is accompanied by an improvement in overall survival. So this is a study in the Netherlands of over 2 million patients with advanced cancer, where you can see the improvement in 5-year survival of patients in 25 years' time. Next slide. And what you see is that there are 2 tumor types that have really improved survival compared to other tumor types. And this is the gastrointestinal stromal tumor, GIST, but also neuroendocrine tumors. Of course, this can be improved much further and is probably also associated with improved care. But you see that the medical therapies that have been introduced in the last 25 years could be associated with a potential improvement in survival for this tumor type specifically. And you see here that despite it only being 8 new treatment options, you see that it performs better than some other types of cancer. But more is needed, of course. So next slide. We, of course, have heard already today about the current options of somatostatin analogs. We now have very long-term data that this is safe, this is well tolerated, and some of our patients can be on for many years on these drugs. Alternatively, you now have a lot of data on PRT with lutetium dotatate. Of course, the NETTER-1 study already showed that this is an efficacious therapy for patients with a mid-cut neuroendocrine tumor, so one in the small intestine. There are now new survival data that show good long-term outcomes, and we know more and more about the risks of this therapy. And there is a calculated risk of about 2 to 3% of bone marrow toxicity, specifically leukemia or leukemia-like disorder. And recently, Novartis, the sponsor or the producer of Lutathera, released a press release that the NETTER-2 study is positive, so it is a good option for patients with higher grade neuroendocrine tumors of the gastrointestinal system. And we're waiting for those results, but it seems to be a potential option more in first line than it is currently advocated. But we have to see in the next few months, I guess. Next slide. There are also new options for targeted therapy. We, of course, have sunitinib already for quite some years for pancreatic NETs. And there's been a study in Asia with surufatinib, which, like sunitinib, is an inhibitor of receptors on the tumor cells. And you can see here that this stabilizes the disease in patients more than it would when these patients are given placebo. And this is now registered in Asia, but not yet in Europe or in the USA, pending new trials. And very recently, last month, there was a study, the KABINET study, that showed a new drug similar to sunitinib called cabozantinib has positive effects on tumor stabilization in patients with pancreatic NETs, but also with extrapancreatic NETs, so intestinal NETs. So this is just out. It's only been released on this conference, and we're awaiting the final results of this trial, but these are very encouraging that potentially give us more options. Of course, also pending the registration of these drugs for this indication by the EMA and other regulatory authorities. Next slide. So there are some new drugs, and I think some other questions still remain in systemic therapy. I think there's still a lot of debate on what to do with some statin analogs. For instance, when there is progression and a non-functioning NET, there's an interesting study from France looking at some of the statin analog maintenance therapy after chemotherapy in pancreatic NETs. but also many studies are ongoing now to improve PRT, either by superior radioligands, more powerful radioactive substances, or because of the combination of radiosensitizers. And these are drugs that sensitize the tumor to more effects of the radiation by the PRT. Of course, a lot of emphasis has been put in oncology on immunotherapy because of its positive effects in, for instance, melanoma and non-small cell lung cancer, but the effects in neuroendocrine neoplasms have been disappointing thus far. But perhaps we need to find the sweet spot and really find the right patients for immunotherapy, or perhaps the right combination for immunotherapy. And I think besides new drugs, it's also important, as has been discussed before, we need to think about sequencing. So we need more data on which drug we should start first when a patient is in advanced stage, but also individualized or personalized medicine, which patient should receive which treatment. So to really find good predictors of which patients are susceptible to therapy with certain drugs. So a lot more to come. Hopefully in a few years we'll have more options than we have now, but I think the future is bright. And thank you for your attention.
Thank you so much. It's good to know that there are things coming up in the future as well, even though we have good options already. So I think we had some questions here from the audience. So one question is, when is surgery not an option?
Sorry, can you repeat that? Was it for me?
When is surgery not an option? So when should you not operate?
That's for Stefano, I think.
Yes.
Who's muted?
Yeah, sorry. I think it's a easy question, but difficult answer, because we have many situations in which surgery is not an option. Of course, we have to consider, first of all, the patient's condition. In some cases, the risk of surgery definitely overcome the benefits of surgery. So in this case, is not an option. But I have to say, apart from the small and indolent forms that I have already mentioned, the most tricky situations, at least in the multidisciplinary decision, is when we are dealing with patients with metastatic disease. We have to consider that surgery can be a good option, but with very selected cases with strict criteria. And of course, we have to exclude polydifferentiated tumor. We have to exclude tumors with spreading outside of the liver. So in all these cases, surgery is not an option.
There's another question there about question 60. What are biomarkers-driven therapies? What therapies are driven by biomarkers?
So that's a very general question, I would say, because I think all our therapies are driven by biomarkers to some extent. A patient has a lot of information, both in his or her telling the story, but as well as the diagnostic procedures that you have. And you use a combination of that to find the best therapy, of course, in your multidisciplinary team. For instance, looking at somatostatin analogs or PRT, uptake on a gallium PET, or maybe some centers still use octreoscan, is also a biomarker for the efficacy of this drug. So having a high Ki-67 or NEC is also a type of biomarker that would shift you towards chemotherapy, for instance. So all these signals and signs that you get from the patients are all sort of biomarkers. So we try to include all of that to find the best treatment option.
Hans, if I may, thank you for your presentation. Do you know how long it will be before the subgroup data on lung nets in cabozantinib is available?
No, I'm not aware of that. No, sorry. I just know this particular main outcomes at ESMO, but hopefully the paper will be there in the next few months.
Okay, thank you.
Another question, 62. What's the best option for second-line neuroendocrine carcinoma at the moment?
That's a good question. So I'm not an oncologist, so I cannot I do not see patients with NEC by myself, I must say. And I know from my oncological colleagues, there is no set second line. There are studies ongoing on second line. Of course, first line is platinum etoposide as the main option. And my feeling is that it differs a bit through centers and countries, what the second line is, but studies are currently ongoing to investigate which is the best second line. But I don't think there is an answer yet.
I agree with you, and I think that the best option would actually be to be enrolled in a study.
Yeah.
To help us to identify the best second line treatment. But there was another question here, which I think could be some important. That is, if we are seeing now that PRT is becoming more and more frequently used in other types of cancer, like for example prostate cancer, but also other kinds of cancer. What do you think, will this new categories of patients overflow the nuclear medicine departments, and our neuroendocrine tumor patients will not have the availability for PRT as they have had now? Is there any fear of that?
Well, that's an excellent question, Eva. Thank you, or whoever was asking that. I think this is a concern we were all busy about. And for instance, our center started with lutetium PSMA a year and a half ago, which by the sheer numbers could easily dwarf what we're doing with PRT, but that's not our experience yet. PRT is still much more common than lutetium PSMA with the current indication. So after it's now like a fifth or fourth line of treatment according to the VISION trial. But this is a concern in the future that would still worry us. So we're also looking now at expanding our opportunities to give PRT, to give other radionuclide therapies, because I think most of us can see a future where there will be more radionuclide therapy in cancer patients. I think the success of PRT for neuroendocrine tumors is now moving to other fields and will undoubtedly bring other radionuclide therapies in our hospitals. So more dedicated centers are needed for that, but those centers that are already performing PRT will have to find a way that this can still go on. I don't think there's a problem yet, at least what I've heard from the centers we collaborate with for NET, but this is a concern for the next few years, I think.
Yes, and there is another question. It's question number 57 that is asking about new kinds of PRT. So there are new compounds that are studied. I don't know how far they have come into the clinic, but I think there are some trials going on. Do you have any news about that from ESMO?
No, I don't think from ESMO particularly, at least as far as I know. I think the NETTER2 will be important to show the effect of PRT in high grade 2 GAPNet and grade 3 well-differentiated NET. These are important outcomes, but also there's the COMPOSE and COMPETE study also looking at lutetium DOTA-TOC, which is similar to DOTA-TATE compared to other treatments instead of the somatostatin analogs. I think this is also very interesting, particularly in the COMPETE, to look at the comparison with capecitabine temozolomide or everolimus or other chemotherapy. This will come in the next few years, I guess. Besides that, there are other developments looking at other types of radiation therapy. So instead of lutetium, for instance, alpha emitters like actinium or lead 212. And these are still at very early stages and in clinical trials, like phase 1, phase 2. So we are looking forward to those results, but these are not there yet. And I think it will be difficult also to prove where they will be in the treatment algorithm, because PRT is now in there. And the question is whether there will be a good head-to-head trial with lutetium DOTA-TATE with new drugs, or whether they will be in salvage setting or whether they will replace BRT. These are interesting questions for the near future, I would say.
And are there any trials going on in Europe at the moment with the likes of actinium and lead?
Let me think. So we're starting the actinium trial in the next year, a phase 1 trial. But I don't know outside of our center in Europe whether other centers are doing that. I know lead, there's a big lead trial in the USA, but I don't know in Europe otherwise.
So it'll be many years before we see that in general use in the population of patients. Yeah, it could be. And another option is radiosensitizers. So that's also a potential interesting option for the future, where you give treatment that will sensitize the tumor to the radiation and perhaps not lead to extra side effects. That's also an interesting modality that is currently undergoing phase 1/2 trials.
So I think we are about to reach the end of this session, but I would like to ask Duncan and Kate, what are your opinion as patients and patient advocates to the need of patients being involved in clinical trials? Because that is how new treatment is, really developed. What would you say?
Well, I would say that you've just got to keep bringing them in as soon as possible, because we have quite an educated population of patients these days. They make it their business to become more involved and to become better informed. And I think from the medic's point of view, you need to take advantage of that more than perhaps we are doing so at the moment. So that's a big take-home message that I would like to pass over.
Yeah, and I think from my side, I think it's important to really think about why you're participating in a trial and understanding what the trial is about. It's important not to see a trial as potentially as a silver bullet. So I think management expectation is key. And I think a lot of participating in a trial is actually, you're not necessarily doing it, you're hopeful that you're going to have a positive outcome for yourself, but you're actually doing it to advance the cause of treatments for patients in the future. So just like the treatments that we're receiving today are a result of trials that have happened years previously, that I think there's quite a lot of, the psychological thought around why you're participating in a trial that needs to be thought about. And one other interesting thing is, there's a lot of trials out there, and understanding what you might be applicable for and meeting the relevant criteria, it can be very tricky and time consuming trying to work through all that data. And at the recent INCA conference in September, there's a new AI tool that's being developed called Ancora AI, which is actually facilitating the process of narrowing down what trials would be relevant for you, given your specific circumstances, your diagnosis, and what treatment you've had to date. So I think that's exciting in terms of developments that are coming down the line. And yeah, I think it's just kind of thinking about it more holistically rather than I'm trying to get as much time as I can possibly for me. You're thinking about the greater good for kind of humanity in a sense.
And also, if you want patients to be more involved, think about the language that you're using as well, because some of the language automatically puts a patient off, excludes a patient because they simply don't understand some of the terminology used. For example, if you look on Ancora AI or clinicaltrials.gov and you go down to the list that talks about the criteria that the patient must hit to be included in the trial, that criteria has got to be very straightforward for the patient to then take that clinical trial to their team to say, is this something for me? Can I be considered for this? If not, why not? Keep the language into layman's terms when you're wanting the patients to be involved.
Can I say that as well? Sorry, Wendy.
Sorry, I think Kate makes a really good point there about the use of language as well, but it's also important for patients to realise, and for us as healthcare professionals to explain, that not all trials are about new drugs. Some of them are well-established drugs or treatments being used in different situations, like when we were talking about the NETA-2 trial and looking to a well-used treatment, but we're looking at different indications, or some of the other trials that have looked around sequencing and in what sequence we actually use treatments that we've got, but using language that is understandable and explaining really what the trial is for is really important. I think sometimes feeling like being a guinea pig for a brand new drug can be quite off-putting for a patient.
I think that many of those points make so much sense, and as Duncan pointed out, is why does the patient want to do this? And oftentimes that's really because of progression, and they want to find other ways of treating their disease. But you know, the recent SCAN survey that INCA did showed that patients really, a vast majority of patients want to know about clinical trials and what's out there and what's available. And you've also mentioned the Ancora AI interface for finding trials, and patients can go to the INCA website and there's a section on find a trial, and that can help them to find suitable trials. And it implements a natural language interface to try and strip away some of the terminology and to help to match the patients to the trials, which I think is really useful. I know we're almost finished, but I did have another question to put out to the panel, which is really about the PRRT. And we've talked a lot about that, and you know, and patients see that as really, it's a fantastic opportunity to help get their disease into check or stable, and sometimes regression. But it's not prescribed for every type of NET, and not every patient is eligible. And I just want patients really to not leave here thinking that that is a golden treatment that they can get. And so, you know, what do you have to add to tell patients in that area regarding eligibility and the prescription of PRT for that type of NET?
Yeah, excellent point, Mark. I fully agree with what you said. So I think it's very important that this is a potential toxic treatment. So especially for patients, for instance, with a low level of disease, which is not fast growing, which is first line, I think something like a somatostatin analog is a preferred option. And then, like in the NETTER-1 trial, when there is progression, you can think about PRT as a second line option. And then you need a well-differentiated tumor, thus far also with grade 1 or 2. The question is whether that will stay the case with a grade 3 in the NETTER-2 study. And you need enough uptake on a gallium DOTA-Tate or DOTA-TOC or DOTA-NOX scan. This is of utmost importance, because if you do not have that biomarker, the radiation will enter the body, but will not enter the tumor. So this is a very important part for selecting patients for PRT. And besides that, you need good function of your bone marrow, your kidneys and your liver. And then still there is this calculated risk of leukemia or leukemia-like syndrome that needs to be taken into account. But these are the most important factors to take into account. And all tumor lesions need to be positive on the gallium DOTA-Tate PET scan. So when the patient is in that situation, for instance, with progression, significant progression, while being on a somatostatin analog, it's very important to make such a PET scan, or maybe in some centers still oxyoscan, and to see whether somebody has enough uptake to be eligible for PRT. And again, bone marrow, kidney, liver function need to be enough to be eligible for that. And yeah, unfortunately for PRT, it's still also treatment which is costly, and there are still local availabilities which might impair availability of PRT, which of course would be very good if every patient in every country would have ample availability to PRT. But looking at the audience today, I realize that this is not possible. So hopefully that this will change in the near future.
Yeah, I think we've run over time, so I think we need to close up this session now and finalize the overall webinar. Thanks so much to you for this panel for the discussion. Thanks to all of our speakers and all of the panel members across the session. I want to thank Eva and the ENETS team for hosting this and allowing INCA to be a joint partner in this. So thank you so much. I hope that patients have really taken a lot from it. I think the discussions have been really excellent. I know we haven't answered all the questions that were put up. If we can find a way to try and answer them, we will, but check back to the INCA and ENETS websites and maybe we can find a way to do that. So thanks to everybody, and I'll hand over to Eva to close out our webinar. Thanks everybody.
Thank you, Mark. And can I have the next slide, please? So thank you all. As you have already said, Mark, thank you to you and to the INCA office for being a good collaborator for this event. I think we had a very interesting afternoon here and a lot of good discussions and information for all of the community. Thank you also to all the people that have been listening. And please complete the survey about this event because it's good for us when we are planning for next year. What you think, what you feel is needed, what you would like to see here. So please visit the websites. And the next slide, please. So also, if you want to see the distribution of centers of excellence in Europe and the whole world, you can go into ENETS website. So this is the QR code to find this. And on the next slide, I would like to thank the sponsors who have helped us make this happen. We are very thankful for the contribution in supporting our webinar. And finally, thank you to all of you. I'm not sure if there was a last slide. Yes. So we will have a webinar once again on the 13th of December, open for everyone about systemic therapies and new advances. So please join us then. And for updates, you can always check our website. Thank you. And thank you to the team behind all of this.